Thank you very much. It's an honor for me to be here, and I thank for the invitation. I need a password to log in into the laptop. But also, I started my medical career as a family physician as well. And one of the motivations that led me to go into sleep medicine was precisely the need to get prepared to treat and manage patients with sleep disorders. Also, the University of Miami is my alma mater, so I feel particularly close to this event because of that. The computer is locked with a password, so I'm waiting to be able to open and show the slides. So I started sleep medicine initially after the fellowship, seeing the full spectrum of sleep disorders, and slowly my heart moved toward pediatric sleep. I now do 100% pediatric sleep at Seattle Children's Hospital and have worked in other hospitals before. I do appreciate a lot the management, the evaluation, and the identification of potential sleep disorder by primary care physicians or other specialties when we get the referrals. So I think we will be covering a little bit of these subjects. There we go. Okay, so let me test this. Good. And good. Perfect. So the goals for today's talks are going to be to discuss the evaluation of children with sleep complaints, to review the diagnostic tools and when to order some sleep studies, and to recognize the most common sleep disorders. I just wanted to bring up this quote by Hippocrates: "Cure sometimes, treat often, comfort always." And particularly in pediatric sleep medicine, we must remember that we're not only treating the patient, but we're also treating the family. Most time when we see infants who are crying and waking up through the night, or toddlers, our patients also become the parents that can't sleep or that their life are affected, their daytime work life is affected. So what kind of patients do we see in sleep children? Well, as you can see, we see the full spectrum. We see children, normal children, who come to be assessed whether or not they're getting enough sleep, or whether the parents are concerned about a particular symptom, or children who are in the process of being diagnosed with another disorder. Children from parents with all backgrounds. So it is very important to identify different cultural practices, co-sleeping, for example, napping, patients who cultures that see snoring as something normal. So we're seeing more and more patients of different backgrounds and different cultures. Children with genetic syndromes, psychiatric disorders, craniofacial syndromes, often children with PTSD, post-injuries when they have sleep symptoms after traumatic brain injury, and a lot of children with medical comorbidities. So what are the most common parental concerns? So these are usually the chief complaint. When we see patients or children or parents in our clinic, they often come saying, well, my child cannot fall asleep alone. I need to stay in the room until they fall asleep. I need to stay or else he won't fall asleep. Or once he falls asleep, he wakes up continuously, like 2, 3, 5 times. They come back to the bedroom, they're crying, they have abnormal behaviors at night. They wake up at 4 in the morning and they're like bright and playful and ready to start their day. Or sometimes they have some awakenings that are not completely normal, that the parent is concerned that they're doing something or that they have been injured. They have breathing problems, snoring, or they can, sometimes it's not necessarily that they know how they sleep. In teenagers, for example, they have their room, they close their door, the parents don't know, they go to the room at 10 o'clock at night, but they're not doing good in school, they're sleepy, they have behavioral problems, and they wonder if there is a problem with their sleep. Or maybe they feel that they are not sleeping enough. So when the parent comes with this complaint, first, just as any clinician in any other specialty, we want to be sure that there's no medications affecting sleep, causing their night awakenings, nightmares. There's no medications that are making them sleepy during the day. If they have seizure medication and they're sleepy, that's really a challenge sometimes. If they have medical conditions that affect sleep, if they have chronic pain, hypothyroidism, if they have seizure disorders, those are very challenging patients to manage because they have other issues affecting their sleep. If there are social concerns. I used to work in Oakland Children's, and every family, I mean, I don't want to generalize, but there were a lot of families that knew about crimes happening in the city, or there were families that lived right above a bar, and the child's room was right next to the window, and they heard all the noise. Or there are children or families that they temporarily sleep just in a room, and they're all sleeping in the same room with children of various ages. They can't all fall asleep at 8 o'clock or at 11 o'clock at night. So some social challenges are very, very important. What is the sleep arrangement? Where do they sleep? What is their environment? What's around them? I used to live in Louisiana for a few years, and when I moved to Louisiana, suddenly I started waking up at 3 in the morning every night, and I was puzzled. I'm like, what's going on? I never had any sleep problems. And right before I was thinking about doing a sleep study, one of my patients asked me where did I live in Louisiana, and I said, well, I live in by the Barksdale station. And then he said, how can you sleep with a train going by at 3 in the morning every night? So knowing the social environment, what's surrounding is very important. Psychiatric conditions, anxiety. A lot of parents come to clinic because the child can't sleep at night and they feel the child has anxiety. But do they have anxiety in the morning as well? Do they have fears? Are they depressed? Do they have other psychiatric conditions? That's very important to evaluate prior to even consider taking the sleep history. So once we have evaluated, ruled out, in other words, these other conditions, then we can start thinking maybe of a sleep disorder. So how do we diagnose sleep disorders? Well, like any good clinician, our clinical history and physical exam are the basics, the basic keys to diagnose. And most sleep disorders could be just diagnosed with a good clinical history and physical exam. But we have other tools up our sleeve, and I'll talk briefly about these other tools that we have. The American Academy of Sleep Medicine also published practice parameters, anticipatory guidelines, position statements. They have a really detailed website with all of this information, as well as the American Academy of Pediatrics. So you can see what the position statements and the guidelines are recommended by the authority societies in our country. So, talking about the pediatric history, well, this is how we take histories for most of our patients. It is very important to know the age and the sex of the patient. It is not the same if a 2-year-old refuses to go to bed because wants a bedtime story than if this same situation would occur on a 12-year-old. It is not the same an infant of 3 months waking up through the night than a 16-year-old waking up through the night. So these are important considerations. It's very important to know the age. What are the comorbidities or medical conditions? And as we'll talk in a few slides ahead, there are some conditions that predispose children to have a higher risk of sleep disorders. Depending on what data we quote, Down syndrome, for example, can have 80 to 100% probability of having sleep disorder breathing. So we really need to know what are the comorbidities, and also what are they referred for. Are they referred for nocturnal awakenings, for suspicion of sleep disorder? When we do a pediatric sleep history, as I mentioned, it is very important to know where does the child fall asleep. Is he able to fall asleep independently? Do the parents have a bedtime routine, and what does that bedtime routine consist of? It is not the same for a 14-year-old child who just turns off all electronics at 9 p.m., jumps in bed at 9 p.m., and comes and says, I can't sleep until 10. That may be appropriate if he's just turning off lights at night without any routine, than an 8-year-old who has a very relaxing bedtime routine of reading books, singing songs, turning lights, dimming lights, a bath. So it is very important to talk about what the routine is. When does the child fall asleep after the lights are off, and whether or not there are nocturnal awakenings. After the child falls asleep, are there any symptoms during the night that are concerning? Is there sleepwalking? Is there snoring? Is there gasping? Are there a lot of leg movements? And very, very important in the pediatric sleep history is what happens when the child wakes up. What happens during the day? Do they take naps? Are they getting good grades? Are they sleepy? Are they cranky? Are they moody? Are they defiant? Very important. So this is just a summary slide. How does the child fall asleep? What awakenings? How many hours? Are there any other symptoms? In the physical exam, it's very important to observe the child. You'll gain a lot by observing the child and the parent. I've diagnosed limit-setting insomnia just by watching the interaction between the parent and the child in the clinic. So there was a family one time that came to see me, 2-year-old or less than 2-year-old child who refused to go to bed, requested water, requested bed stories, and the parent came to visit because of insomnia. So as I was observing the interaction, the child was running all over the clinic, grabbing at everything, pulling every instrument, opening doors, and the parent didn't do anything about it. The child would open the door and start running down the hallway, opening other clinics and other visits, and the child was saying, well, I'm sure that the parent would say, I'm sure you're used to this behavior. So what I did was I told the parent, well, grab the child and sit the child on your lap for 5 minutes so I can continue talking to you, and this was not possible. The child kept getting up, the parent had no control, and you can really realize that this same behavior is going to happen at night. So there is no limit setting in this situation. What's the body habitus? What's the appearance of the child? What are the behaviors? Is it eye contact? We can aid in the diagnosis of autism because insomnia is one of the common presentations. And we can, in many, many times, we have recommended consult by developmental pediatrician just by seeing the behavior of the child accompanied by the sleep problem. Important to get vital signs, body mass index. In terms of the face, it is very important to identify the facial structures, the bony structures, whether it's macroglossia, there is a palate, and I'll have some pictures about it. The rest of the exam is pretty much similar to other specialties. We want to see if there is like a short thorax as well, scoliosis, if there is significant hypotonia, if there are depression, anxiety, and skin issues like eczema, which can disrupt sleep. So in this case scenario, I have pictures of some of my patients, which I didn't include in your package because of permission for the parent, but some of this have been published. So this is a child with Prader-Willi. You can see hypotonia. This child was not walking at this age, obesity. Child with achondroplasia, mid-face hypoplasia, small thoracic cavity, frontal bossing, high risk for for sleep disorder breathing. As a matter of fact, the Academy of Pediatrics recommends that children with achondroplasia must have a sleep study in the first year of life, and due to the high risk, not only of obstructive sleep apnea, but central sleep apnea. This is a child with Pfeiffer syndrome. This is a craniosynostosis, mid-face hypoplasia, high risk of obstructive sleep apnea and sleep disorders. This was one of my, they're all my patients. This actually, we ended up treating sleep disorder breathing with a tracheostomy. So recognizing the risk factors, the appearance, the concerns that make these children a higher risk for sleep disorders. Children with Pierre-Robin sequence, retrognathia, significant retrognathia in these syndromes. This early to identify, early to do sleep studies. Sometimes we do it as early as at birth, and interventions are needed due to the high risk of sleep disorder. The retrognathia impinges of the airway and causes a high risk of obstructive sleep apnea, same as Stretcher Collins. Here we have a child with Down syndrome. Down syndrome is pretty much our poster child for sleep disorder breathing. They are at high risk of obesity, hypotonia, large tongue, hypertrophy of adenoids, hypertrophy of lingual tonsils, high index of obstructive sleep apnea. The American Academy of Pediatrics recommends to have a sleep study before the age of 4, and this is one of the few situations in which it's regardless of symptoms. So whether or not the child snores, whether or not there is evidence of sleep gasping or breathing pauses, the child needs to be referred for a sleep study by the age of 4 due to the high risk of sleep disorder breathing. Muscular dystrophies, you can see muscle weakness, hypotonia, also in the face, which could make a challenge for CPAP, for example. All of those things are important to note and to see when you do your physical exam. Adenoidal phases. So obstructive nasal airway with large adenoids causes the child to mouth breathe day and night. And if the child is young, in between toddler age and school age, this affects the growth of the face because you have an obstruction in the nose, mouth breathing, the mouth is open, the face grows narrow. So there is a lot of evidence in which that by age 4, the face is still only 50 to 60% formed and the bones continue growing. If the tongue is not sitting at the base to shape the growth of the maxillary bones, the face will be narrow and the palate will be high. And it is very important to treat these patients early so the bone and the face grows accordingly. Tonsils, large tonsils, you see the uvula, the tonsillar hypertrophy, important to grade accordingly. We use the Brodsky system, which I believe I have an exam. Look up at the palate. And see if there is a high arch palate. So you see the teeth, this is looking up. High arch palate, there is orthodontic procedures that we can recommend in these children, like a palatal expander. People do it as early as 4 years old. You just have to have the molars. And as early as 4 years old, is it called rapid maxillary expansion? It expands about 1 millimeter a day and then stays in the mouth for about 6 months. The group in Stanford does it at several times in growth. I think they do it first at 4 and then at 8 and then before 13. If you wait too long, by the age of 13, the mid-palatal fissure fuses and then it's harder. It's not possible to do it unless there's a break. So we do it as early as possible, and we want to detect these children early because modifying the palate will be something that will have a longer term consequence. It'll open the airway both vertically and horizontally. We use the Brodsky scale to categorize tonsil size, and usually 0 is not tissue present or surgically removed, 1 between the pillars, 2 you can see the tonsils peeking outside of the pillars, 3 is like the example that I showed that they are enlarged but there's still, you can see the airway in between, and 4 they're your typical kissing tonsils. We also use the Mallampati score to see the visibility of the airway with the mouth when we ask the child to open the mouth, and if we see everything is score 1, and if we see nothing is score 4, depending on the amount of pillars, and uvula that we see is 2 and 3. There is a role for imaging in sleep medicine, and I actually order it often, and if there have been a good number of studies that correlate a soft tissue X-ray with tonsillar and adenoid size. So if you look at the literature, they actually have done studies between just the X-ray imaging and the actual finding during surgery or during an endoscopy, and there is an excellent correlation. So my colleagues from otolaryngology, often they prefer to do the endoscopy and look through, but if you do not have access to an endoscopy, there is excellent correlation between just a soft tissue X-ray. And most of the time, what I use the soft tissue X-ray is when children have already had an adenotonsillectomy. I'm contemplating the idea of starting CPAP, and I don't know if they have regrowth of the adenoids. So that is a quick, easy way of saying, hey, yes, your nasal airway is open, we can proceed with CPAP. So in this case, we can see the large tonsillar tissue here. Sometimes we can use MRI imaging when we're suspecting, in this case, for example, there is a Chiari malformation. So in children who have a lot of central apneas, abnormal central apneas, we refer for imaging to rule out any central nervous system pathology. So you can see here the cerebellar tonsils protruding downward, which is a Chiari. This is a case that I published with my colleagues from Louisiana, a 2-year-old girl who had a posterior fossa tumor removed with surgery. You see the scar here, and this is the brain stem, and you can see that the scar is at the area of the brain stem. This imaging was done after we did a sleep study, as a matter of fact. So this is the hypnogram of her sleep study, and a hypnogram is a bird's eye view of all the sleep parameters through the night. So you can see the saturation dropped into even the 30s, and these are the amount of obstructive apneas, which was amazingly high. So there was a suspicious, why is this child doing this? Why is there such a degree, severity of obstructive sleep apnea? When we did a physical exam on this child, there was fasciculations on the tongue, and we suspected hypoglossal nerve injury that was after surgery, because this is the exit of the hypoglossal nerve. So there is a role in imaging in sleep medicine, both CNS imaging and airway imaging. This is a child with Goldenhar syndrome. Goldenhar is hemifacial microsomia, so they have asymmetry in the face. One side is underdeveloped than the other, the same as one ear. So they have microtia, underdevelopment of one side, and usually they also are at higher risk for sleep disorder breathing. So this child is about 8 years old and had severe obstructive sleep apnea, already had tonsils out, adenoids out, and we were trying CPAP, nasal CPAP on the child, and the child was not able to tolerate it, not even for 5 minutes. And I was like, what is wrong? Why wouldn't he tolerate it? He felt suffocated. He was older enough that he was able to verbalize that he just felt like he could not really breathe. And we did a CT scan imaging, and we found, and because of the hemifacial microsomia, the underdevelopment of the maxilla in this side, with an upward displacement of the maxilla, with the teeth actually inside the nasal cavity. So this poor child had an obstruction, but it was a mechanical obstruction caused by the underdevelopment of one side of the face, with teeth blocking the nasal cavity. So this was a very simple initial procedure to remove the teeth from the nose, and as a matter of fact, we repeat the sleep study and was much, much better. So again, a role for imaging. This is what I was mentioning before about children with achondroplasia and why the American Pediatrics Academy recommends a sleep study. So children with achondroplasia, and you may all know this, have decreased foramen magnum with stenosis of foramen magnum and risk of compression of the brainstem. We have the pacemaker of respiration in the brainstem. So compression of the brainstem can actually cause breathing pauses called central apneas. And long, prolonged, or large number of central apneas, as well as hyperreflexia, are reasons to do foramen magnum decompression in these children. Now, this foramen magnum stenosis continues per life in children and adults with achondroplasia, but it's very important to image and do sleep studies earlier on to see if there is compression, to release that compression earlier. Diaries is another tool that we frequently use in our patients. So we give them, and there are many, many diaries all over, and sometimes the patients just can't do their own diary or their own notebook, or the parents. If they are teenagers, I ask them to do it themselves. If they are small children, the parent will do it. So usually what we do is we do an arrow down at the time that they go to bed. We ask them to darken the times that they're asleep, and an arrow up when they come from from bed when they wake up, also during a nap, or if they do any awakenings. They're free to write any other events that can happen, like if they took melatonin, if they took any other medication, or if there was a stressful event. Sometimes parents of children of divorced parents spend the weekend with one parent and the rest of the week with others, and they just mark which days. It's a very useful tool. It's also a useful tool when we are evaluating excessive sleepiness. Actigraphy is actually our more objective tool, is like a watch. I try to say like a Fitbit, but it's not really a Fitbit. It is validated, and it gives us more detail, including light, dark, and more detailed information. This is, for example, the way an actigraphy report would look, with lightened areas, dark when the lights were off, and moments of activity and no activity. Also, black and blue areas when the child actually took the actigraphy watch off, which we see when they're trying to say, well, I was asleep and I wasn't moving, but they weren't really using the watch, or when they're showering and the watch is off. The American Academy of Sleep Medicine has practice parameters and recommendations, and these are the reasons why actigraphy is recommended, mainly in the evaluation of insomnia, or also in the assessment of circadian rhythm disorder. Is not a strong recommendation, but also mainly in the assessment of insomnia, in the assessment of excessive sleepiness, when we are thinking that the child has narcolepsy and we're going to do a multiple sleep latency test. It is not recommended for evaluation of restless leg syndrome or periodic leg movements, which is the last recommendation. Our gold standard tool for evaluation of children with sleep disorders is polysomnography. Polysomnography, it's a study that is done in lab in children, and as its name says, poly, many graphs, many parameters. So we have a limited EEG, we have sensories for breathing, for movement, for pulse oximetry, capnography, and we make it very child-friendly. Sometimes we have to set up the parent or set up a teddy bear. We give brochures with pictures as a storybook teller, so the parents can use it as a bedtime routine to tell the child what's going to happen before this study. We also give sample leads for the parent to place the leads before the study so the child can be acclimated. Very, very rare there is a child who does not tolerate the study, and it happens maybe once every 6 months. Usually it would be your teenager with anxiety more than any other conditions. Polysomnography is recommended in any case that you suspect sleep disorder breathing in a child. If there is a suspicion that a child has a breathing problem at night, there is an indication for polysomnography. But there are other indications that are non-respiratory, and one of them is if you suspect a hypersomnia of central origin, like narcolepsy. If you have parasomnias, which we'll talk briefly, and they are injurious, they are atypical, they're not really fit the typical, what you would really expect a parasomnia to be, and you're suspecting there is something else. Or if there are suspicious of movement disorders and the history is not clear, you need to confirm that this child indeed has periodic leg movements or indeed has other movement disorders. We have our Bible of Sleep Disorders published by the American Academy of Sleep Medicine, the International Classification of Sleep Disorder, and as well our Academy sets the scoring manual criteria for events, and this is what we use to diagnose. It has the diagnostic criteria for all sleep disorders, and the classification is mainly divided in 6 main groups of sleep disorders. So when you do see the ICSD-3, you see that it's divided mainly in these 6 groups. Circadian disorders, disorders of hypersomnolence, movement disorders, breathing disorders, parasomnias, and insomnias. So let's talk briefly. I'm going to touch very, very briefly. We could spend months talking about these disorders, but I'm going to give a brief introduction to the main groups of disorders. So I'm going to start with circadian disorders. So we all have a clock, and this is exactly the same way I talk to parents. We have a clock. It is the suprachiasmatic nucleus, and the clock is regulated by the handles of the clock, which in this case are light and melatonin. So light, the presence of light shuts down the production of melatonin, telling the clock that it's daytime. The absence of light makes the production of melatonin, telling the suprachiasmatic nucleus and our brain that it's nighttime. There are other ways to synchronize via activity, rest cycles, food, social cues, but light and melatonin are the biggest, strongest, and as well as our biggest, strongest tool. Sometimes I tell parents that it is like a jet lag. Like if a child is not used to sleeping until 2, 3 in the morning, I said, well, these are your options. We can move you to New York, or we can use light melatonin to adjust. So I try to explain to parents, just like when they have a jet lag and they go to Europe and visit Europe or New York or other, I mean, for you guys, New York, that wasn't the right example because I am in Seattle, so moving them to New York would really change their time zone. So it would be like, let's move you to Europe, let's move you to the West Coast to adjust your cycle, or let's use melatonin and light. So I tell them that it is just like when you travel to Europe, you have about 5 days to adjust naturally. When they want adjustment, they also have to be patient when we're using melatonin and light to move the cycle and adjust it to a better time. I traveled to Haiti when the earthquake occurred in 2010, and I was very concerned that there was no light, that we were in tents. As a matter of fact, the University of Miami had a hospital over there, and I was part of the relief group. And I was very concerned because I usually go to bed at 11, and I was thinking, well, there's no lights, there's no tents. Well, as soon as I was there, when the lights went out and we went into tents, I fell asleep probably by 8 o'clock at night and woke up at 4 or 5 in the morning with the rooster and the sunlight. So we do have a functioning circadian clock. If your circadian clock is functional, if your visual pathways are functional, it works. I tell the parents, it's going to work. Now, what happens is that naturally, at certain ages, our circadian changes, and it's natural. Like, for example, toddlers, all of those of you who have toddlers, 2-year-olds, naturally, they're a little early. So they go to bed at 7 and they wake up at 4:30, 5 o'clock, happy, playful, ready to have breakfast and ready to start their day. And the parents are like, can you help me have him sleep until 7? And unfortunately, there are situations in which we gotta tell the parent, remember the first slide, treat, sometimes comfort always. We gotta comfort and say, hey, this is gonna go away. This is just a growing stage, and it's not worth the risk of giving them something. Just let them be. So the same way adolescents are moved later. So in adolescence, the circadian clock naturally moves later. Later as of 11, midnight. But what happens in adolescence is it gets compounded by the fact that they are on social media, that they are on electronics, and then suddenly their circadian clock is set at 2 o'clock in the morning. So when I have families that have children of various ages, one of the challenges is to tell them, you cannot expect your teenager to go to bed at 9 o'clock anymore with your school-age child. Even worse with your toddler at 7. And as much as it's convenient for the parent to have older children go to bed at the same time, it is just not physiologically acceptable because the children are going to be sitting frustrated and not being able to sleep. It is very important to consider that you do have to have a normal functional circadian system for this to work. So children who are blind, it won't work. Patients who have some alteration, and talking about adults, there's degeneration of the circadian, the suprachiasmatic nucleus in patients with dementia, it may not work. So the system has to be intact. When we talk about parasomnias, we talk about abnormal things that occur at night. And we have main two sleep classes, and in non-REM we have 3 and REM is 1. So the same situation, we have parasomnias that are typical in each of these phases of sleep or stages. So the non-REM parasomnias are the most common parasomnias. Children sleep really deep, and a lot of times parents come to me and say, I really can't wake them up. Well, they sleep really deep. Their slow wave sleep is really deep. My very first mentor in sleep medicine used to say, if you pick up a child out of deep sleep in N3 and put them on their feet, they'll start sleepwalking. So that's as it is. So they're very, very common. They have some genetic predisposition. So if the parents had sleepwalking, or the grandparents, or the brother, there is chances that they will also have it. Sleepwalking, sleep talking, night terrors, confusional arousals are very benign. The main thing is that you have to advise the parent in safety measures, and you have to be sure that this is a non-REM parasomnia. So what I mean by non-REM, it occurs early in the night. It occurs usually one time. It can almost be predicted at what time. Like the child goes to bed at 9, by 11 o'clock they start sleepwalking, and then they don't do it anymore at night. That's very, very typical. If it happens, and we'll talk later, but if it happens at various times, if it happens many, many times during the night, then it could be a little atypical. Most typically, they happen once at night within the first 2 hours of sleep. And sometimes, and there is no injuries. If there is injuries, then we need to explore further. Non-REM parasomnia, the most common in children, most benign, are nightmares. They're very common in younger ages. But we also have a parasomnia called REM sleep behavior disorder. It is extremely rare in children, and when it happens, it is always abnormal, and it is a reason for referral. The REM behavior disorder is manifested as dream enactment. So it's common in older men, in patients with Parkinson's disease. They're dreaming that they're being chased, and then they get up of bed and run into the closet, or they jump out of bed and hide under the bed. If you ask them what happened, they will recall a dream, which is different from sleepwalking, night terrors, and confusional arousals. The child will not recall a dream. When to refer, any time that there is an injury. You can see a bruise here. This was a girl who got up and ran in the middle of the night and got a bruise, and she had such a severe obstructive apnea that it wasn't REM behavior disorder, it was just she was confused and got up. Anytime that you suspect REM behavior disorder, anytime that you suspect that there was secondary enuresis, the child was continent and started having enuresis again, and you suspect that it's due to a sleep disorder, and anytime that you suspect that these abnormal behaviors are actually nocturnal seizures. And when could they be nocturnal seizures? When they are stereotypic, when the child repeats the same things over and over, like bicycle, like moving the arms, when there are repetitive events through the night, or there are abnormal postures. Sometimes they would just like look like they're having dystonic postures at night. When the timing occurs at different times, not necessarily at the same time, but it can happen at 11 and at 2 and at 5 or any time. And also when they're like really brief. Usually parasomnias could last like up to 10 minutes or 15 minutes in night terrors, but the seizures are usually very brief and repetitive through the night. And it is very important to refer for a sleep study. Obstructive sleep apnea is another reason. And sleep disorder breathing is another sleep disorder. The pathophysiology in children varies, is not always due to the same thing. It can be hypotonia, it could be excessive tissue, tonsillar hypertrophy, muscle weakness. It is many, or a combination of factors. In this study shows that remember I mentioned about the exam, the physical exam, and the history. Well, in this study, it shows the predictive value of the physical exam and the historical features. So if you have a child who has tonsillar hypertrophy, or a child who snores more than 5 nights, these are their positive and negative predictive values. And if you see they're like 60, 67, 65, not really good. So we do not have really something to say, well, yeah, these things are convincing that your child have obstructive sleep apnea. They're usually just 60 positive predictive value or negative predictive value. So this is one of the reasons why we do sleep studies in children, because we have had children with 3+ tonsils who snore, and we have normal sleep study, and we have children with 1+ tonsils and very loud breathing, and we have abnormal sleep study. Very, very low predictive value on this. The highest predictive value that we've had is actually if the parent comes and say, my child stops breathing, and that only has a 79 positive predictive value. So the diagnostic criteria for obstructive sleep apnea requires 2 things. One is to have symptoms, to have snoring, daytime symptoms, but the child must have abnormal findings in polysomnography. An apnea-hypopnea index of more than 1 for children, or obstructive hypoventilation, which sometimes people forget. So we have children with normal apnea-hypopnea index, but who have CO2 levels of more than 50 torr for half the night with loud snoring, paradoxing, symptoms during the day. That child classifies for obstructive sleep apnea. We also use pediatric rules for scoring of events which are missing 2 missed breaths, and this is an epoch of one of our polysomnographies. This is a 1-minute epoch. So you can see on the top the EEG leads, the eye leads, and the respiratory leads. So this is nasal, oral, we have chest and abdomen belts for effort, and we have capnography and oximetry. And we can see that the child is breathing, and normal breathing here, and then suddenly there is a pause that lasted at least 2 breaths and a flattening of the light. That is how we score an obstructive apnea. And you can see that there is still effort on the chest and the abdomen belts. This is how we grade obstructive sleep apnea in children. So anything more than 1 is abnormal. We call it borderline between 1.1 and 2, so it's like very borderline. From 2.1 to 5, mild, moderate, up to 9.9, and severe, anything more than 10. Now, why do I have this little asterisk here? Well, because we are allowed to call in children older than 13 to score it as an adult if a 13, 14-year-old has the body habitus of an adult, like if there is a child who is as tall as we are, weighs as much as we are, is 14 years old, well, and has an apnea-hypopnea index of 11, we're not going to classify it the same as a 2-year-old. So that was the Academy of Sleep Medicine gives us that clinical criteria that we can discriminate as clinicians and say, hey, you know, you don't really have severe apnea, but it's mild. So these are options for treatment for mild apnea. The most cases of severe in this published study, as we can see, are in the little ones. So severe is the dark square, so obstructive sleep apnea tends to be more severe in younger. Now, also with the presence of comorbidities like obesity and hypotonia and other syndromes, we can see severe obstructive apnea in older children. So talking about a little bit about the movement disorders, this is actually the very, very first publication that was made on restless leg syndrome. And this is actually a little bit of a historical treasure because this was written by Dr. Eckbund. That's what is called Eckbund disease, Willis-Eckbund disease. And if you see up here is in handwriting the very first PAPA paper. So this was provided to our group by Dr. Eckbund's son. This paper was a case series of 5 patients that complained of paresthesias. So this talks about really the importance of case series. Anyone who wants to Google me or put my name in PubMed, you'll see that a lot of my publications are case reports. And don't disregard the case reports. If you see something really interesting and different, publish it. So this is the lesson. Most situations in history of medicine have started publishing by small case series. This is a drawing of a child of how do they describe restless leg syndrome, like ants on their legs. So it is very difficult to really understand restless leg syndrome in small children. But if a children is able to verbalize and explain their symptoms, the criteria is quite simple. Urge to move the legs. It occurs mostly during sleep, and it's really alleviated by movement, by getting up and move. Now, periodic leg movements, though, are the leg kicks that occur during sleep, which is different. Now, a lot of children with restless legs will have periodic leg movements, but not all of them. So it's very important to differentiate. Both conditions are linked to iron deficiency. If suspected but not clear, we can order a sleep study, and it is very important that both conditions are highly prevalent in children with ADHD. So screen all your patients with ADHD for nighttime symptoms and nighttime movement disorders, because ADHD is a 24-hour condition. When we do see in a sleep study, again, polysomnography, and this is the video, the periodic leg movements are characterized by dorsiflexion of the foot and are seen in the leg leads as this kind of artifact, this kind of signal. We have a specific criteria also to identify this and name the periodicity. Sleep-related rhythmic movements, on the other hand, are different. It's body rocking, head rolling, head banging, and these are very common and typically in young children, even starting at 9 months, and usually resolve spontaneously by 5 years of age. Commonly familiar. I actually had a set of triplets that had body rocking together, and it was really cute. And one by one, they started growing out of it by age 5. Reassurance and prevention of injuries is what is important. And in this case, although I don't have a video, but this child is moving back and forth, and we see the movement on the sleep study. Insomnia in children, it's most likely in small children, the reason that we see patients for insomnia is behavioral, and is either limit setting or sleep association insomnia. Commonly, a primary care doctor refer patients for insomnia, and it's a lot of the times is a combination of inadequate sleep hygiene, or is seen in combination with another disorder, like in neurodevelopmental disorders or depression or anxiety. It is very important that it's very, very high prevalent in children with autism spectrum. I'm not going to talk about this today, but the one data that we do have in children with autism spectrum is that they do have a dysregulation of melatonin secretion, so these children do respond really well to melatonin supplementation. Refer when behavioral interventions are not successful after 3 months. I am so convinced in situations of sleep onset association and limit setting that the behavioral interventions work that I never give follow-up appointments to these patients. In my mind, giving them a follow-up appointment is almost setting them up for failure, like allowing them to fail. It's not going to fail. You do this, it's going to work. So this is very, very rewarding when the parents are invested. Very, very frustrated when the parents are not. But most of the time, if you really explain to the parents what the sleep associations are or the limit setting and provide them positive routines, then it will be successful. There is no gender prevalence of behavioral insomnia. I never diagnosed any child of behavioral or insomnia until the month of 6 months. And I was commenting early with someone that we do have a few number of parents that at 3 months or 2 months, they want their babies to sleep through the night, and that is really unrealistic. It takes about 6 months for the circadian clock of that infant to get entrained, for the melatonin production to be adequate. So no diagnosis up to 6 months is just part of being an infant. Now, the one things that we can do before 6 months, we can prevent associations. For example, do not let the infant fall asleep while breastfeeding, because you will create an association with breastfeeding. Do not let the infant fall asleep while rocking, or you will create an association with rocking, and then we will have to get the child out of that association. So whatever the child falls asleep with, that's the child will have an association falling asleep with, and while they wake up through the night, they will require that. They will need to be breastfed to go back to sleep. They will require to get rocked to fall asleep. I've had situations in parents that are so traumatic that the family has actually bought like this kind of bouncy thingies that they hang from the roof, and the nanny or someone has to actually sit on it and bounce the child up and down. And when did that association get to that level? I don't know, but prevent those associations. The best scenario is the child lays in the crib to sleep independently, alone, initially with a parent there for safety and comfort, but not with much intervention. Hypersomnia. Majority of patients that I get referrals for hypersomnia are not sleeping enough. So ask the patients how much are they sleeping. This is very challenging for teenagers. But most of the time they're sleeping 7 hours, even 6 hours, even 7.5 hours. For teenagers, they need to sleep at least 9 hours. So most of the causes of excessive sleepiness during the day is not getting enough sleep. But it is very important not to miss narcolepsy, which often presents starting at 9, 8 years of age. So one of the things that make me suspect of narcolepsy is usually a really dramatic sleepiness that is out of proportion. The diagnostic criteria says it has to be at 3 months. The patients that I have really strikingly sleepiness is, well, the child fell asleep on their birthday party. That's not normal. The child fell asleep during a soccer game or watching a football game. That's not normal. So those are things that really caught my attention. We diagnosed a medical student who actually had to have his books open over an ironing board with the iron turned on, or else he would fall asleep. So this kind of degree of sleepiness. Falling asleep on my lecture could be normal. Falling asleep in school could be okay, acceptable, understandable. But falling asleep in this really outstanding, dramatic situations. Cataplexy, pathognomonic. If the child has some weakness under strong emotions, it's pathognomonic of narcolepsy. And the key in children is that it is not as in adults as we imagine cataplexy. They don't drop to the floor. They usually can't hold the pen, or they start having slurred speech. And please be sure that they are not like from another country and they're speaking like an accent with me before diagnosing cataplexy. But it is slurred speech. It has weakness of the face. The parents say the face becomes asymmetric. So it's very subtle in children. And we order a multiple sleep latency test. So part of this is my last slide, but it's very important to know what has done in the past. How long have they tried? Did it work? What factors contribute to failure? Because often we have behavioral insomnia of childhood that we treat and it fails. But then what happened? The child gets hospitalized, the lights mess up their circadian clock, and then the parent comes and say to you, well, the sleep doctor recommended this, it didn't work. Well, it worked. It is just that other situations occur and contributed. Children are going to relapse really often. Every time that they're sick, the parents will have them sleep with them to watch over them. That creates a new association. So children will relapse. Giving the parents this information really helps. This is going to work, but in 6 months it can relapse again and go back to square zero. Repeat again the same steps. New medications. It was working. He wasn't sleepwalking anymore, and then started an antihistamine medication, and it all happened again. So this is very important. Weight gain. The child did stop snoring after tonsillectomy, but now he's in the 97th percentile in weight. So now things have changed. And also very important to know what is the parent's goal for the visit, because sometimes we do not match, and we need to find a common ground. What is really the parent's goal? Often the parent's goal is a letter for school, and then we have to just address that as well, because we're treating the family. But it's very important to know what's the whole family's goal for the visit. In conclusion, we have common sleep disorders in the whole spectrum and can vary from any of the ones that we mentioned. The parental concerns are wide as well, and it's very important to know what's their goals for the visit. There are a lot of populations that are higher risk, and we need to identify them with a personalized history and physical for each child in particular, and know when to order the appropriate tests. I hope to have a couple of minutes for questions. Thank you.
Is what strategies do you have to promote compliance of the patients that have developmental delay, like Down syndrome, autistic kids, that you need to commit them to CPAP or BiPAP, and the parents are very frustrated, and we don't have anything else to offer except of tracheostomy that they are not really very up to?
Great question. So I just gave a talk on CPAP, on pediatric CPAP, actually in Uruguay. And one of the publications that I'll be happy to share with you or with the committee to distribute was compliance of CPAP in children of various backgrounds and conditions. And there were two populations that were the most compliant, two. One of them was neurodevelopmental, and the other one was girls. So don't dismay. It is very common perception to say that the neurodevelopmentally developed children will not be compliant. So the one thing that I do tell parents is to have a realistic expectation. And the realistic expectation is that it's going to take time, that it's going to take effort, and it's going to take consistency. So consistency is include the CPAP in the bedtime routine only. Don't have them practice during the day, because then the child associates the CPAP with the bedtime routine. Always use nasal masks in children because of the risk of aspiration and everything else. And sometimes in some, like when you say you have to go to tracheostomy, well, if I am contemplating tracheostomy, the step that I do before tracheostomy is to have a night nurse. So the night nurse will put the CPAP mask continuously through the night until the child gets used to. The one thing that always works with children and works, as it always works, is bribery. So we have methods to positive reinforcement, like we have CPAP ferries, sticker charts, CPAP prices, and we had a child, as a matter of fact, the child in the photo with Prader Willi, the parents actually, we had months and months, the child needed to be compliant with the CPAP and wasn't, and she needed to have growth hormone. And the parents asked her simply like that, what do you want? I want a tricycle. Okay, use your CPAP. And that night started happening. So don't underestimate the power of bribery. In other children, severe Down syndrome, severe autism spectrum, consistency is the key. Every night, slowly, don't give up. I had to wait with children up to a year sometimes to get used to, but when they get used to it, it's worth it, because then they're used to for life. So. Very challenging, very challenging. I have admitted a couple of those patients, and that again is very dependent specific. In UCSF in California, we had a lot of freedom for admission, and we admitted the patients to have the same repeated position and placement. And I must say, there are certain, well, in those situations with pulmonary hypertension and everything, it may be worth admitting for a few days for compliance. And yeah, it is challenging, very first. But don't give up, because the consistency and time is the best thing. And I guess we don't have the answer all as a team. We're still all battling with that. Any other question?